Hey team, welcome. We're moving on to another section in our exploration of bleeding control and shock in trauma patients in the pre-hospital environment. So our discussion in this phase is going to be surrounding bleeding control. So we'll be talking about managing external and internal bleeding in the pre-hospital environment, focusing on changes that were made in the PHTLS 9th edition update. We'll be talking about the use of external bleeding control devices, including the use of direct pressure, tourniquets, junctional devices, and hemostatic agents. And then we'll also talk about internal hemorrhage control with the use of antifibrinolytic therapy like that of TXA. Some clarification and additional resources for you. I'm not going to necessarily show step-by-step how to use each of these devices, but I'll talk about their use in general. If you want to find videos and other resources on how to use these devices, I highly recommend, if you haven't done so already, going out and getting access to either the app on both the Google Play or the App Store, Deployed Medicine, or going to deployedmedicine.com. The team, ladies and gentlemen, at deployedmedicine.com have done an excellent job at making resources available for management of patients that are suffering trauma. Wow, look at that picture. So this picture is of a person who was run over and cut by the propeller on a motorboat. And the patient certainly has massive injuries, and left untended for very long, this patient would have severe blood loss. It's likely that they were essentially insanguinating as the first responders arrived, but this patient survived and was taken to the hospital, which we can see in this photo, only because they applied very rapidly 2 tourniquets, 1 on each leg at least. And so the quick thinking of those first responders has helped save this patient so they can make it to definitive care. And that's essentially what our 4 questions that are going to guide resuscitation are going to help us to understand. So the first thing is to say, what type of shock is this, and where is the patient in the progression of shock? What's likely going to happen next versus where are they at right this moment? What will manage this patient's shock in total is the second question. And we're not necessarily talking about our treatment. We're talking about definitive care. So if for some reason you have definitive care, you're the person providing definitive care, great. Then you probably answer the next 2 questions. But in most cases, our patients need to be transported to trauma centers or at least facilities that have surgical capability in patients that have shock, especially those that have major injuries that require surgery. So our question is, where will definitive care be, and what can I do in the meantime? And so this is where the work of the paramedic is done. Part of it is to get off scene and recognize the patient's condition rapidly. The rest is what we do en route. And in many cases, we're actually not going to do a whole lot to make our patient better because our hands are going to be full just trying to keep them from getting worse. If we can, then certainly we want to start trending this patient back towards health and maintaining their vital signs. But in some cases, it's not possible. So at very least, want to stabilize them so that they don't get worse and they survive our transport to definitive care. When we're managing patients that have lost, not just they're in shock, but they've lost actual blood volume, we do want to think about what that has done to the patient's cardiac output. Always keep in mind this cardiac output formula, which is essentially talking also about blood pressure as a result, is made up of heart rate times stroke volume. Now, when patients have lost red blood cells, it's likely that we're talking about the most important thing to replace being stroke volume, because that's what they've lost. Their overall volume has left the blood vessels, left the body, and so the body is going to try and compensate, as you recall, by increasing heart rate, and it can also try to increase force of contraction. But on its own, it's not going to replace that volume very quickly. So that's where we come in. And so prioritizing what we're going to get done for this patient is extremely important. As an important subject, I want to highlight that again in PHTLS 9th edition, we're not using A, B, C, D, and E any longer. We're using X, A, B, C, D, and E to highlight the importance of stopping any major bleeding. And so that's with insanguination. So if we had all the resources in the world and we could manage this patient en route to the hospital with things like blood products, that would be the best case scenario for patients that have lost red blood cells. When you lose red blood cells, you also lose plasma and all the clotting mechanisms that are within it. So there's huge risks that this patient, if they have internal hemorrhages as well, is going to continue to deteriorate en route. Critical thinking is warranted when we're managing patients in general, but with sick trauma patients, there's a lot that the paramedic's going to have on their mind, and it's an evolving process. So one of the things that we're challenged with when we arrive on scene with patients that have massive trauma is trying to determine exactly what needs to get done on scene and what can be done en route. Part of this is prioritization so that you can leave the scene, hopefully within less than 10 minutes of arriving. And so that long scene time, 10 minutes or more, is going to delay the transport of the patient towards the definitive care. And so one of the hallmarks of this is if the patient has a life threat that has to be managed, the question is, can it be managed temporarily with non-invasive or even BLS level skills until you get into the back of the ambulance and can transport? An example of what you might have to make a decision on for airway includes if the patient's actively vomiting, we're going to need to clear their airway before breathing and ventilation can take hold and respiration follow. Now, it's important that we don't stay on scene for too long when we don't have to, but in some cases, it may be that you can only manage this patient's airway long enough to get into the ambulance by starting intubation on scene. In most cases, though, this won't be the case. You should be able to get by with basic maneuvers, and if basic maneuvers and the use of a BVM without oxygen is keeping your patient alive enough to get to the ambulance, whatever length of distance that is, then that's what you should stay by. We very rarely will be in a position where we need to start an IV or take blood pressures on scene. In fact, the only cases where this might happen is when you're dealing with patients that are maybe entrapped or there's a prolonged scene time for some reason outside of your control. In those cases, if you're going to utilize those treatments, they're not going to be the major factor delaying your transport. What can be done to improve the patient's circulation? And so this is where we'll work on some of our shock maneuvers. And one of the most important that we can do even on scene is to manage the patient's hypothermia. So remember, try to keep the patient warm, add a blanket, and these should be right up there with the care that you're going to give for airway and breathing. Let's explore some of the bleeding control mechanisms and devices that are available to the paramedic and outlined in PHTLS's 9th edition. You know, back in the old days, I guess, if you will, we actually didn't have tourniquets associated with our care. There weren't any commercial available tourniquets, and we were actively told not to utilize tourniquets if we could avoid it. So in those days, we had things like direct pressure, which we still utilize, followed by elevating an extremity and trying to hold manual pulse pressure at a large blood vessel, say in the axillary region for an upper extremity bleed. Those things weren't as successful, and there certainly were conditions in which the patients absolutely needed a tourniquet, and because one wasn't available and we weren't necessarily trained to utilize them, we made them out of just whatever we could. Things like our belt or blood pressure cuffs became our means of tourniquet for large arterial bleeds in patients. Now they recommend utilizing direct pressure initially for external hemorrhage and then applying a tourniquet. When you apply the tourniquet, you don't want the patient to move around, so you're probably going to have to immobilize, and certainly very important if the patient has something like a compound fracture or a fracture that's causing bleeding. There's also topical hemostatic agents that can be utilized for prolonged transport and in situations where the tourniquet isn't going to be as effective alone. There are cases in which going straight to the tourniquet is very important. And so those cases are if you have a tourniquet readily available, like out on your belt in one of your pockets, and it's already looped and ready to go, then you could utilize it if it's not going to delay any treatment of the bleeding. But often we'll apply direct pressure first while we're assembling our tourniquets and before we apply that pressure. Direct pressure can be kind of complicated. If you look at it just as a fluid dynamics evaluation, then we're trying to basically overcome the amount of pressure that's in the vessel causing the leak by holding external pressure, direct pressure over the hole in the blood vessel, and that pressure that we hold above that side just has to be higher pressure than the pressure inside of the vessel. And so that's essentially the idea behind transmural pressure. Well, what we'll do is we'll apply usually a gauze or 4x4 or some type of bandage directly over the site. You're going to obviously have your PPE on, and you may need to consider something like a face shield or eye protection when managing severe bleeds. As we apply that pressure, we never want to take off the 4x4 of the gauze. Remember that it's basically providing for us artificial framework that clots can start to attach to in patients that have large blood vessels bleeding. When we're holding pressure over that site, though, once we start direct pressure, if blood seeps through the first gauze that we apply, never take the first gauze off, just add another gauze on top of that. Also, when we're managing patients that require pressure over long periods of time, you need to have some plan and some resources so that you can actually free up your hands as the main provider and tend to other things. Generally, if we had to apply direct pressure to stop bleeding, we probably should keep that applied all the way through to the hospital to avoid resurgence or breaking of clots. So some considerations that are unique when utilizing direct pressure. One is to consider when we're managing patients that have an impaled object. Remember that the impaled object might actually be holding pressure itself, artificially basically tamponading up against the sides of that blood vessel that it cut. And so if we remove that, when we find them and it's impaled, if we remove that, we might actually cause them more harm by letting the bleeding occur more rapidly in the absence of that device blocking it. So we don't want to remove impaled objects essentially unless one of two things is a concern. We can remove impaled objects if we have to manage the patient's airway and the impaled object is preventing us from doing so. The other is if we have to perform CPR on a patient and the impaled object is preventing us from being able to do that, we can consider removing it. Just realizing that those patients are in the worst case scenario and we're going to have to act fast and we may be making their condition worse in the process. When we utilize direct pressure, we can free up our hands by using things like the Curlex elastic gauze roll and wrapping it around tightly. Make sure that when you're wrapping it around, you're holding the amount of pressure that essentially you were achieving pressure with, but not enough pressure to cut off blood circulation distally. There's also commercial pressure bandages that can be utilized. These are very useful tools, especially in large extremity bleeding. And if you really had to and you had no other resource available to you, you could utilize something like a blood pressure cuff to maintain that pressure in absence of your hands. Remember that bleeding is going to always need to take precedence in our management evaluation over things like replacing volume with an IV. When we utilize certain tools, though, that are useful for some bleeding control, things like abdominal pads, for example, abdominal pads aren't going to hold any pressure. And so taping an abdominal pad down over a site just absorbs blood. It's still leaving the body, but it isn't enough pressure on its own to hold pressure against that blood vessel. So we generally will have to use some other device to secure that. There's evidence-based medicine through studies that were performed in the Iraq and Afghanistan war. In the Iraq war, Ibn Sina Hospital, or HBO's Baghdad ER was another name for the hospital. In fact, that's the hospital where the study was done. Evaluated casualties that had extremity injuries and had tourniquets applied in the field. In some cases, these patients had tourniquets on for a number of hours before it was released and the patient went during patient's surgery. They found that there were no long-term effects negatively on the patient's extremity just by applying the tourniquet, including there were no instances of long-term neurological deficit. So that means that tourniquets are going to be a very valuable part of our bleeding control and management. Now, you can fashion a tourniquet out of a number of things, including triangular bandage, and I recommend that you play around with that well before you have patients that need that, because a tourniquet needs to be applied very quickly, and if you're trying to figure it out on scene, it may fail. So that's what we're showing here. It's a manually created tourniquet. These two tourniquets at the bottom are actually commercial tourniquets, and both of them are approved by the Committee on Tactical Combat Casualty Care. One is the CAT tourniquet, and the other is the Soft T. Rescue Essentials makes the Soft T. This is in its I believe, 4th generation, and CAT is made by North American Rescue, and I believe it's in its 7th generation. Keep in mind when you're purchasing tourniquets for yourself or for your department, you want to make sure that it's the actual tourniquet and it comes from a reputable source, and generally you can tell it's the right tourniquet because it has an NSN number on it. There are copycat tourniquets that are being created. Unfortunately, they're created to look exactly like the actual tourniquets. They're not made with the same equipment or materials, nor are they made with the same quality standard as the reputable original sources. Unfortunately, because they're a little bit less expensive and they're retailed on major retail websites online, they're prone to be purchased by individuals who maybe don't have a big budget and by departments who are also facing budget crunches as well. Tourniquets have been utilized and purchased in actual fire departments by first responders and others and used on scene. So in those instances, there have been tourniquets applied to actual bleeding patients whose life depends on the tourniquet working, and the tourniquet failed. Let's look at this story from the CBS Evening News discussing counterfeit tourniquets and a bulletin that was put out after an actual event occurred in New Hampshire.
Tonight, we have learned that counterfeit tourniquets are finding their way into the emergency gear of firefighters and police. The fakes break easily, which could leave an accident victim bleeding to death. Jeff Pegues found a bulletin for law enforcement.
This bulletin went out to New Hampshire first responders after paramedics experienced a catastrophic failure with 2 counterfeit tourniquets at the scene of a motorcycle accident. Sources say a rod like this snapped in half as the paramedics tried to stem a hemorrhage on a victim with a leg injury. That made it impossible to tighten the tourniquet, a failure that could prove fatal. The counterfeits were knockoffs of the Combat Application Tourniquet, or CAT. CATs are made by a company called North American Rescue. It says it has sold nearly 13 million tourniquets to the military and first responders over the last decade. During the wars in Iraq and Afghanistan, tourniquets proved so life-saving that the U.S. military tried to give one to every soldier on the battlefield. In late September, the Obama administration will roll out an initiative to put tourniquets in public places, office buildings, and schools. But with fake tourniquets, some possibly made in China, being sold online for a third of the actual price, manufacturers fear the knockoffs will end up in the public's hands.
So make sure that you're finding an actual reputable brand of tourniquet. I recommend purchasing from the supplier just to make sure that you have the right thing. Now, before we move on too much further, why don't we look at the actual structures and terminology that goes into these commercial tourniquets? It's important that you understand these structures because the instructional videos will reference them quite often when you're trying to learn how to use them. Now, there's 2 types of tourniquets, again, recommended. One is the CAT tourniquet and the other is the soft T, and they both essentially have the same basic structure. On the CAT tourniquet and the soft T, both of them have what's called a windlass, and this is the bar that you'll actually twist. That twisting is going to wrap the band of the tourniquet around this device so that it tightens circumferentially around the extremity. But since we're tightening it around, when we tighten it, if we let it go without having some means of securing it, it will unravel, and that will lead to the loss of our bleeding control. And so usually after it's tightened and you've achieved bleeding control and there's no pulse present distal to the application of the tourniquet, then we're going to fasten the windlass into either the clip on the CAT or into the triangular clip on the soft T. Also, when we're applying the tourniquets, it's important that we apply a time by placing a piece of tape that has time and initials applied to it. And on the CAT tourniquet, there's a little band here that covers the windlass clip, and you can write on that as well. When applying tourniquets, it's worth mentioning that there were a few different ways to apply tourniquets and different procedures in the past. Now, though, we've got enough evidence to have a pretty solid understanding of what our approach will be. When we're utilizing tourniquets, they could be applied even if the patient has bleeding that you aren't using direct pressure for. In those cases, though, you must have the tourniquet ready and available, and it doesn't have any delay in going on the patient. Otherwise, you need to hold direct pressure while you're fashioning the tourniquet and preparing it for use. Tourniquets can be applied on both the arms and the legs, and so generally multiple tourniquets need to be in your kit. You don't know if one tourniquet's going to work on one extremity, or will the patient have injuries that require tourniquets on multiple extremities. When we apply it, we're going to apply it very, very proximal to the injury. Generally, you want to apply it all the way high in the groin for the lower extremity injuries, and high in the armpit or the axilla in upper extremity injuries. When we're applying the tourniquet, it's important that people know that it's there, and we want to make sure that people know it's there by communicating to them. We're going to use some tape to identify the time, but we want to make sure that it's immediately visible to anybody. When patients have tourniquets applied to them in the tactical setting, often these tourniquets are black, but most tourniquet providers now design tourniquets that are often in orange, red, and blue colors so that it stands out even in night when it's not required to be black for tactical concerns. When we apply a tourniquet, you need to document and create a piece of tape that has the time and your initials as to when that tourniquet was applied. You can put that directly over the windlass on the tourniquet so it's readily available to anybody who accesses that tourniquet and assesses it. When we apply the tourniquet, it's important that we not only stop bleeding, but we need to cease all blood flow to the patient's extremity, including distal pulses should be absent after the tourniquet has been applied and bleeding controlled. Now, why is that? I think it's worth a small discussion. Let's say that we've got the bone in the center of an extremity, and this is the outside diameter where the skin is, and we've got these blood vessels scattered throughout. Arteries are generally going to be located up against the bone or very deep in the patient's anatomy in the extremity. So when we first apply pressure through the tourniquet, it's going to apply circumferential pressure all the way around against the skin. And in that process, it starts to push down and compress blood vessels from the outside, the superficial, towards the deep, inward. The first vessels to collapse are going to be vessels associated with the lymph system. Lymph system is a set of capillaries and nodes that helps evacuate extra fluid and waste outside of the interstitial space. It's spread throughout our entire body, and they're very, very, very low pressure systems because they just rely on the drainage difference between the inside of the blood vessel and the pressure that's on the inside of the interstitial space. Lymph vessels are compressed when patients have things like a snake bite, and commercial snake bite kits have tourniquets in them that only apply small amounts of pressure. In fact, in some cases, the amount of pressure that's created when you put a rubber band around somebody's wrist is enough to close most lymph vessels. Now, that's important to know because the lymph system is evacuating fluid out of the tissue in that extremity. So once we start collapsing it, and it certainly may not be enough pressure to stop bleeding at that point, once we start collapsing the lymph vessels, and then the next level down, start collapsing the veins well before the artery is collapsed, we'll have cut off all the evacuation blood flow returning from the extremity going back into circulation. But in that process, if we don't tighten until a pulse is absent, the artery may still be pumping blood into the patient's extremity. In that case, the patient will have blood pumping into their extremity, but not leaving the extremity, and no means of getting fluid out of the interstitial space either. In those cases, two major concerns will come up. One, it may actually cause more pressure and may increase the bleeding that's occurring in the patient in general, making it harder for our tourniquet to be successful. The other idea, though, is we can end up with compression or compartment syndrome because of that accumulating pressure and nowhere for it to evacuate. So we generally want to apply a tourniquet so that bleeding stops and there is no distal pulse. The tourniquet should remain in place until definitive care is reached, surgical capabilities most likely. Do not loosen once it's been tightened, and continually monitor to make sure that it doesn't have to be tightened over time. This is going to be very painful, so you should consider using pain management in patients that can achieve that based on their hemodynamic status. Some steps in applying tourniquets, very easy to use, but I do recommend that you practice using this. You should also practice applying tourniquets to yourself because the incidence of violence against first responder is increasing across the country. When we apply the tourniquet, you want to apply the tourniquet high in the extremity, as close to the core as you can, so high in the groin or high in the armpit or axilla. You're going to start to tighten by twisting the windlass, which is the bar on top of the tourniquet. You're going to twist that windlass until you stop the hemorrhaging. Now the key though is once we twist the windlass, it's going to be wrapping the band of tourniquet around the windlass itself. And so it's wanting to, because we've tightened it in one direction, it wants to unravel in the opposite direction. So if we just let it go and there's no management of the windlass, it will loosen altogether, unfortunately. So once we have tightened it, we want to make sure that we secure the windlass in place so that it can't unravel. Both of the tourniquets that we've have available to us in commercial have little areas that the windlass will attach to. When we have placed a tourniquet, we want to document and apply a piece of tape that has the time that it was applied in our initial onto the tourniquet itself. Also document the tourniquet application time on your chart. Try and make sure that it's visible, uncovered, and give the report so you can transfer to the person that's receiving patient care that they shouldn't cut that area until a physician's evaluated it and made sure that it's okay. If bleeding still is occurring or it occurs after the application of a tourniquet, add another tourniquet directly next to the previous tourniquet. This is basically going to double the surface area of the tourniquet, tightening down and give a better approach to compressing the blood vessels. Again, anticipate pain management and transport immediately, generally to a facility that has surgical capabilities. Now, whether or not you use a tourniquet, there may be cases in which a hemostatic agent is warranted to control major bleeding. So hemostatic agents are agents that are going to be applied. Most of them now are impregnated in gauze, so they're not necessarily a powder or a fluid that you'll mix, although there are a few out there that are foam. When we use the impregnated gauze, we're going to be packing the wound, and it's important that we know what packing the wound in this case means. We generally don't pack wounds in patients unless we're applying the hemostatic agent. Now, the hemostatic agent is going to work primarily by applying direct pressure of the hemostatic agent right at the point where the patient is losing blood. So it needs to be touching the actual blood vessel where the hole in the blood vessel is. In some cases, we may need to, with the gloved hand, scoop out large volumes of blood that has pooled inside that wound and other debris so that we can get this device all the way down to the blood vessel that's bleeding. Once we've placed that, we're going to put our fingers directly over it and pack the gauze continuously by holding pressure and sliding the next piece of gauze under our finger. Now, hemostatic agents that are available today should be applied as part of that impregnated gauze directly at that site and have pressure exerted on it for at least 3 minutes. Now, once that pressure is applied, you should continue that pressure and can again use external pressure dressings to do so. The way the hemostatic agent works is it's impregnated in gauze, so the gauze creates a framework where the clots can start to accumulate. Now, it's going to help aid in the clotting aspect as well, and that's the hemostatic part, or the hemostatic agent. Once we've applied this, we should be able to control major bleeding. It may be that we have to use this in addition to a tourniquet as well for extremely high pressure blood vessels and wounds. This is a picture of a few major types of hemostatic agents. C-LOX gauze is available and approved by the Committee of Tactical Combat Casualty Care. And here we've got quick clotter combat gauze, and essentially we've got the civilian version for hiking and camping and the version that the military has as well. You might have one of these different types, which you can see right off the bat. They're all foldable gauze that's impregnated with the agent. Some information about older agents. Hemostatic agents currently in the generation that we have in the field today does not create a exothermic reaction. In the past, our early generation of hemostatic agents created heat in the process of the chemical activating and working to create clotting, and that heating caused tissue damage and extreme pain in some cases. Also notice that it's not a powder or liquid form. There were agents in the past that were just a powder poured into the wound and not impregnated in gauze. There were some risks of using that, especially when there was any breeze or wind nearby. That powder could blow up and into the eyes of the provider or up into the eyes of the patient. It just needs water generally to activate, and if it finds that in your eyes, it will start to activate, and the exothermic reaction did cause damage to tissue. Now, though, we have much safer generations of hemostatic agents. Now, some types of bleeding aren't going to be easily controlled with the tourniquet because of the location. The junctional in junctional hemorrhage devices is talking about the point of an extremity attaching to the trunk. And this includes the patient's neck. So if we have injuries that are very close to the trunk, unfortunately, it may be too proximal to where we can get our extremity tourniquet to be applied. In this case, they're generally very large blood vessels, so major bleeding is going to ensue. The Committee on Tactical Combat Casualty Care currently has 3 junctional hemorrhage devices that it approved. The first is the Combat Ready Clamp. We see some pictures here. Combat Ready Clamp, the JET Junctional Emergency Treatment Tool, and finally the SAM Junctional Tourniquet. Now, there's a whole lot of different steps involved in each of these devices, but the big idea is that we have some type of application of pressure right at that point where the large vessel is bleeding at the junctional part of the trunk and the extremity. Suppliers of these devices include Combat Medical Systems, North American Rescue, and SAM Medical Products. These devices generally have to be purchased with a prescription or medical director authority involved. Now, we've talked generally about injuries and bleeding that's occurred in the extremities or at the junction. Again, when patients have bleeding that occurs in their torso or in cavities that we can't reach, that internal hemorrhage can be a major factor in the patient surviving or not surviving. The biggest thing we can do to help manage patients that have bleeding that we cannot control is recognize that bleeding early, initiate transport, and go to the appropriate facility. Okay, so managing patients' life threats. It's important that when we manage patients' life threats, we're again trying to evaluate what do we need to prioritize for our scene care versus what do we need to prioritize for transport. Also, if you're the lead person on a call, Now, in order to prioritize our care on scene versus the care we give during transport, again, we want to try to minimize our scene time in critical trauma patients to less than 10 minutes. It may be useful for you to designate someone, or you yourself, if you're hands-off on that patient care, designate someone who's hands-off on the patient care to start a timer at the point you've arrived on scene. Their goal generally should be to watch the time and give you updates when you're 5, 7, 8, 9, and 10 minutes elapsed on scene. Having this will help you avoid the tunnel vision that can suck us into tasks that keep us on scene for very long periods of time. Unfortunately, the scene care generally passes very quickly, and our knowledge of the surrounding time that's occurring may be dilated or constricted based on the adrenal response that we have. So try and delegate that to someone. In some cases, have dispatch call you in 8, 9, 10 minutes if you don't have enough resources. Remember that we need to control bleeding that we can identify and control, and recognize bleeding that can't be controlled. In fact, recognizing bleeding that can't be controlled early is the best treatment for that patient's uncontrolled hemorrhage. Ensure the patient has a patent airway at all phases. Manage the patient's airway with BLS maneuvers until ALS maneuvers are required. Provide 100% oxygen as ready and soon as possible. Loading the hemoglobin that the patient has left circulating in their blood volume with extra oxygen, or making it easier for oxygen to attach to hemoglobin, may make the difference between life and death. When we assess a patient's LOC and all their vital signs, generally for critical patients and 3 to 5 minute intervals, make sure that you're assessing a GCS. Realize, though, that if the patient has a decrease in their mental perfusion because of shock, the GCS may be abnormally lower than otherwise predicted. GCS gives the best presentation of a patient's LOC and brain function if the brain has perfusion. And as always, we want to make sure that we're managing patients' hypothermia risk. You should be uncomfortable in the back of the rig and set the rig to about 85 degrees Fahrenheit as recommended by PHTLS. Remember that hypothermia can contribute to patients decreasing blood clotting effectiveness. Not only did the loss of red blood cells and administering of crystalloid solutions change the body's ability to clot, having hypothermia slows the clotting process further. Also, the shock position is no more. Now, supine is fine for shock patients. It was of the past that we used something like the shock position or Chandellenberg, in which the patient's feet were elevated. This was thought to promote drainage back into the core for circulation of blood. Unfortunately, it's been found that in some cases, patients had increased intracranial pressure and increased intrathoracic pressure, causing detriment to the patient's survival. With this last slide, it's just a reminder that there are some challenges that we face in trying to estimate patients' actual blood loss. However, we do have some tools, so you can use this chart to help identify if a patient has a fracture of one of these bones, how much blood loss is estimated to be associated with it. Now, when using this, remember that patients that have injuries involving the femur and especially the pelvis can have catastrophic amounts of volume loss inside their body, not losing a drop of blood to the outside world, and they may do so without showing any outward signs like a distended abdomen. Okay, as we get ready to wrap up, let's look at a drug that's associated with helping our patients that are suffering internal hemorrhages. Generally, we don't have a lot of tools that we can utilize, and so recognition early and rapid transport to appropriate facility are among some of the best tools that we have. However, there's an expanded discussion in the PHTLS 9th edition around the drug TXA. TXA is a drug that's going to inhibit fibrinolysis. These patients that have started using their clotting cascade generally also have the release of chemicals that will break down clots as well. TXA seeks to stop that process of breaking down clots so that clots will form for longer periods of time and more easily. Patients are able to receive TXA in cases in which traumatic blood loss has resulted and the patient is a candidate for large volumes of blood to be transfused. We generally need to administer this medication within 3 hours of the patient's initial injury. Contraindications include, as always, our hypersensitivity, but also subarachnoid hemorrhage, thrombosis or thromboembolism, and patients that are less than 18 years of age. Usually this drug is packaged in increments of 1,000 milligrams or 1 gram, and in some cases it will be given in 1 gram inside 100 milliliters and infused. Complications of the drug can include a decrease in blood pressure. And in fact, if the patient has a decrease in blood pressure after you've infused this medication, you do want to consider slowing its administration down. Usually that will be enough to stop their decrease in blood pressure. All right, so in review, remember that we need to make sure we're recognizing bleeding in trauma patients early on. And so that should start at the beginning of our assessment. Very early stages. Remember, X, A, B, C, D, and E is now the primary assessment outline. And so exsanguination is before all others because it's that important that we control their external hemorrhage as soon as possible. In addition, we need to make sure that we're recognizing and leaving scene as soon as possible so that we can get the patients to a surgical suite within the appropriate level of definitive care at a hospital nearby. Now, the next set of lectures is going to discuss the use of fluid in managing patients that are suffering from shock and that have lost large volumes of blood. If you have any questions, please let me know. Please hit subscribe and leave some comments below. Always look forward to hearing what you have to say and making our product better.